Welcome to the Registry Insider. I'm Bill Seifarth, CEO and Executive Director for the National Registry of EMTs. And today we're talking about community paramedicine and mobile integrated health. Are they the same? Joining me is Dr. Alex Ulintz from the Ohio State University. He's an EM doc or emergency medicine physician and an EMS researcher. So Alex, thanks for joining me today.
Thanks for having me.
So the question as I toyed it up here is, what is the difference between community paramedicine and mobile integrated health, or are they the same?
That is a fantastic question. The way that you often see it represented now is community paramedicine - mobile integrated health. So I think intuitively, we're trying to describe that they're kind of the same, kind of different. Community paramedicine, I think, has a slightly clearer definition as things stand right now. So the way I think about community paramedicine is this is a non-traditional use of EMS resources to fill a community gap, a specific aim or a specific need that the community has. We typically see that run through an EMS clinician working in a slightly expanded role outside of the traditional role of emergency response, emergency transport. I think we'd both agree those are the two most common functions that you pick anyone off the street, they would say, this is what EMS does. They drive to places, they save lives, and they drive you to the hospital. Community paramedicine, in my mind, is anything that falls outside that typical rigid paradigm. Common examples that we'll see in the EMS world is a post-geriatric fall outreach team. So someone falls in their home. There's many reasons that could happen. There's lots of things EMS clinicians can do to intervene. Installing grab bars in the showers, removing rugs from the home, going through medications and identifying ones that may be predisposing to falls. I think we both agree that falls out of the traditional driving lights and sirens to a scene, but it's certainly something EMS clinicians are capable of to make those changes and fill those gaps in their community. So I'd say community paramedicine, very kind of tight, aim-focused, how do we use this EMS resource in a non-traditional way?
Okay. And then contrast with mobile integrated health is there's clearly a difference between the both.
So mobile integrated health, I don't think anyone agrees on what it is yet.
Okay.
And I think I say that in a good way. I think it is rapidly evolving, adapting in communities to their needs. And there is something about MIH that differs. The things that I think are consistent among MIH programs is a few things. So one, it uses the EMS clinician in a non-traditional source. But two, it ties that kind of, we're focused on one specific aim to a broader goal in the community. So that could be, we are trying to reduce geriatric falls, not only by the post-fall EMS team, but we also want that team to talk with primary care. When the community paramedic in the home notices, let's say hoarding, that they're able to get in touch with County Agency on Aging and get in social work resources, mental health resources. It takes the community paramedicine mindset of how do we adapt this EMS clinician to the immediate needs of the community, but it also asks the question, how do we bring the community into that as well? So it's not this one-way street of always putting another thing on EMS's plate. It's how do we leverage the access, the trust, the tools that EMS brings within the community, and how can the community better help EMS to address those unmet needs?
So obviously with the words community paramedicine, the assumption is they're all paramedics. Is that the case?
So I used to think that. And I think as traditionally described in the early 2000s, that was the intention. There's a recent paper that came out of the National Registry of EMTs where we actually looked at the nationally certified EMS clinician population, and we simply asked them during their annual recertification, how many of you serve in MIH roles? And we found nationally about 1.5% of all nationally certified EMS clinicians serve in an MIH role. 42% of those were EMTs. So it calls into question this, yes, the normal moniker has been community paramedicine, but EMTs play a huge role in this space.
Yeah. So in terms of education and competency verification and certification, obviously the International Board of Specialty Certification, IBSC, has community paramedicine credential. What are the education requirements on average for community paramedicine versus mobile integrated health? And obviously, as I said, for CP or community paramedicine, there's at least a credential that can be obtained. But what's the education requirements?
So the educational requirements vary. And part of that is state-to-state variation and what each state wants to see in someone given the title community paramedic. And I think part of it goes back to what role is this person functioning in the community? Is this community paramedic simply following up on falls and installing grab bars following a certain protocol? Or is this someone who's going through a medication list and calling a primary care doctor to ask, hey, can we potentially switch these medications? I would argue that those are two different sets of competencies that I would want to see. The CPC certification that you mentioned, I think is probably the most robust education that you can receive right now. Covers everything from social determinants of health to pharmacology to how to do a community health assessment to figure out what your community's needs are. So I would say that all comers, that education covers a broad swath of things. However, in reality, sometimes community paramedics are focused on a more narrow scope, and they may actually be overeducated from that standpoint.
So you mentioned at the beginning, your response to the last question, it varies from state to state in the education requirements. So there's no universal standard per se for either, correct?
Correct. Okay. And that has been a larger discussion of what are the roles that are being done and what is the education and training needed to fulfill those roles. And because this varies so much between agencies, states, and the community needs that they're filling, I think it makes it really hard to set a standard of this is what every single community paramedic nationwide needs to be able to do.
Cool. So again, from that staying on that same kind of theme, from state to state, there's variability. What about the regulations and the legislative track? Is there any legislation that's cooking right now that may perhaps be of interest for some more states getting clarity with this?
Yeah. So the big push right now throughout the COVID pandemic, we saw a lot of repurposing of community paramedics and MIH programs to perform hospital at home functions. Can we keep people safe in their homes and avoid exposure to other things in the hospital? So there are payment mechanisms set in place where community paramedics doing hospital and home care, we're getting reimbursed for it. Outcomes seem to be great. We're able to pay our frontline medics who are doing the work. That said, with the sunsetting of a lot of these funding mechanisms, there's now this gap between, well, now we're kind of back to EMS gets paid for treatment and transport only, not all these non-traditional things that they can serve. So there is currently some legislation making its way through the House, I believe, that is starting to look at, can we pay EMS for these non-traditional roles?
So there's, as with traditional EMS, there's challenges and some ambiguity or variability with the reimbursement. So that's still a battle to be won or some clarity to be gained.
It is. I will say that there has actually been an interest among private payers and insurers to fund some of these community paramedicine programs.
Which makes sense because it's more cost effective for them.
Yeah. So we see lots of examples of Aetna and Molina are two that come to mind of funding pilot programs that are now sustainable for their members of we can dispatch a community paramedic and we could potentially not have to readmit you to the hospital for your heart failure exacerbation again. We can simply have the paramedic do an initial assessment, do a telemedicine visit with your cardiologist. We can diurese you in your home. We can check up on you in the same day. Patients happier because they're in their home. They're healthier. EMS gets to perform this function that they have always been performing, but get reimbursed for it. And the payers seem to like it because it's a heck of a lot cheaper than sending you to the hospital for a number of days.
Sounds like a win-win-win situation for all involved.
I would agree.
Have you felt that there's an increasing popularity in MIH and CP? As we talked about a little bit earlier, there's some legislation that's pending. There's some regulations that are being drafted and a lot of kind of consensus being gained. But are you seeing this on a positive trajectory to continue increasing, or is it plateauing, or what?
There is such an appetite for changing how healthcare is delivered. And I think community paramedicine, mobile integrated healthcare is on the forefront and the cutting edge of that. One of the barriers that I have noticed in talking with colleagues outside of the emergency medicine and EMS sphere is just under recognition of what EMS is capable of. I hate to say it on here, the dreaded phrase ambulance driver, but that tends to be the predominant perception still. And I think there's undereducation of the people we should be teaming up with to deliver MIH if they don't realize how well trained EMS clinicians are. They don't realize how flexible the scope of practice can be with an engaged medical director. And they don't realize that you could transform how healthcare is delivered in community by partnering with EMS. A common example is when you talk to a primary care office or a federally qualified health center about the things that they need help with, they will talk about it in terms of care flows or care streams. And they think that that is different than an EMS protocol. And when you sit down and you look at what is the function that EMS is serving here, it's darn near identical. So I think there's a huge appetite for reducing the amount of time someone needs to go to a pharmacy, doctor's office, a hospital. There's a huge appetite for having care delivered in the home.
Mhm.
There's a huge appetite for having EMS clinicians have a role outside of just emergency stabilization and transport. So I see this both from on the EMS side of clinicians being interested in it, on the community side of patients wanting it, on the hospital side of wanting less boarding hours in their emergency departments, on the payer side wanting more efficient healthcare. I think MIH is the solution to this. So to answer your question directly, I think this is just on the early upslope of what's going to be a growing industry.
Add to the mix the aging population we have and the longer lifespan that people are living. So the demands on the healthcare system will not be able to be met alone by the healthcare system. So this is a creative alternative that can very well meet the patient's needs and be perhaps at a lower cost.
Yeah.
Who is the right person for this? I mean, you said earlier, 40-some%, I think it's 42, 43% are EMTs, but in terms of an EMS clinician, who is the ideal person for this role? Or is this someone that's been around for a couple of decades? Is this someone that's newly certified, or do we know anything about that?
Fantastic question. I would say that is the number one question I've heard from medical directors around the country. If I'm interested in starting this program, who do I tap within my system right now to do this role? The easy answer to your question is we have no idea.
Mm-hmm.
The more difficult question is, well, how do we go about figuring that piece out? What I can tell you in talking with both EMS clinicians and EMS medical directors is there's a recognition that has to be some intrinsic motivation on behalf of the EMS clinician to fill this unmet
Mm-hmm.
need in their community. And in talking with the boots on the ground folks, it's almost like a discernment process or a calling of, I've in the last year, I've done 30 overdose runs at this address. And my gosh, I just don't want to take another call. And not in the sense of I'm burned out and I no longer want to provide care, but recognizing that there's limits to what emergency response is capable of. And I want to dig deeper and I want to figure out what can I do for this person to help them get better.
So this specialized aspect of EMS offers career growth, career advancement for EMS clinicians, both in a depth and a breadth perspective as far as their professional trajectory, from what I'm hearing.
Absolutely. So it allows you to, in many ways, expand on what you've been doing for however long you've been in EMS and kind of take that next step into, well, what was leading to all these calls that I went on? What is something that I can do on this call and link someone into another service in my community? What other services are available in my community to help with this piece? And certainly as part of that, there's going to be a plethora of education and training opportunities as new job roles open up in this MIH space. EMS clinicians are going to be front of the line for those roles.
So I mentioned earlier that IBSC has a certification for community paramedicine. So we know that exists as a standard for competency measurement. Are there any education opportunities or associations or a champion for community paramedicine or mobile integrated health?
So I'd say right now there's a coalition of folks who are interested in it. Certainly from the EMS medical director side, NAMSP has been very interested in both legislative and regulatory pieces of MIH. National Association of Emergency Medical Technicians has been a fantastic resource as well, particularly on the education, training, and understanding what do frontline providers who are doing this type of care, what are they doing and what do they need from the larger associations in terms of training and support. And then the National Association of MIH Providers is a third group that really brings together a number of services outside of EMS. So we're talking pharmacy, nutrition, social work, folks who work on social determinants of health, and bringing them to the table as well. Because as we transition from narrow community paramedicine, still housed within EMS firmly, to MIH, which is certainly more interdisciplinary, we're going to need multiple people sitting at that table, multiple stakeholders there as well. So those would be, I think, the three organizations that I see really leading the charge. As part of that, many of them will have educational curriculum or have members who are providing those education.
Cool. So to recap that, so NEMSP, National Association of EMS Physicians, NAEMT, and finally the NAMIHP.
Correct.
Cool. And I'm assuming, obviously, I know NEMT does, NEMSP does have a website, but I'm assuming the Mobile Integrated Health Association does as well.
Yes, they do.
Cool. All right. So folks can go there to find out more about it. So what are some other pieces that perhaps we haven't touched base on as it relates to community paramedicine and MIH that people might be curious about and you feel that needs to be as relevant, should be shared?
That is a really good question. The number one thing that comes to mind is understanding how do we advertise this and how do we pay it? Those are the two questions that I hear from medical directors and EMS clinicians across the country of, I have this program and I'm still siloed within EMS and I'm having a hard time getting the community to recognize that I do more than emergency response and transport. Part of that, I think, is an EMS branding thing. Part of that is learning how to build bridges to other groups that do similar work to community paramedicine, mobile integrated health groups in the community. The payment piece, I think, is a little bit more tricky. We've certainly seen pilot programs out the wazoo. So we know that there's appetite to fund these things. That transition from a pilot program or grant to more sustainable funding, I think, is where we're still getting stuck. Certain state legislatures are looking at different ways to change their reimbursement mechanisms where you can get paid for the care that is provided as opposed to the dispo decision of driving to an ER versus not driving to an ER. Federally, like we talked about earlier, there's legislation making its way through of, can we reimburse this on a hospital at home type mechanism? I'm really excited to see where that ends up. And I think it opens the right conversation of how do we pay EMS for the functions they serve rather than the EKG that was done and driving to a hospital. They do so much more than that day in and day out. And to get reimbursed and recognized for that work, I think is probably the biggest thing that goes undiscussed, not necessarily within the EM or EMS community, but I think within the broader healthcare system, that under recognition and in some ways under appreciation.
What are the limitations for mobile integrated health and community paramedicine? I mean, obviously we talked about there's clearly there's a lot of variability. There's no consistency as it relates to the standard curricula that they're educated in. So there's no national standard curriculum or education standards like there is for EMR, EMT, advanced EMT, and paramedic. Education's perhaps a challenge. The regulatory gap is perhaps a challenge or an opportunity. So what are the limitations and challenges, if I would, related to CP and MIH?
So I think that comes back to how do you educate, how do you train, how do you regulate something that we're still arguing what it is and what the boundaries are. I think one of my big concerns for early standards in community paramedicine and MIH is that I think part of the secret sauce to it is you have a trained EMS clinician, an engaged medical director who know what their community needs and are tailoring a service to meet that specific goal. And in some cases, that's where early regulation can maybe even stifle innovation or ability to execute some of those things. Now, that said, I think we would both be in agreement that having some sort of educational standard for a growing industry involving EMS clinicians is likely going to be needed at some point. But I would want to have greater clarity around who is doing it, what are the boundaries, and what do we need to train and educate to get someone to actively thrive in that within those boundaries.
So in other words, before we kind of box it in with regulatory constraints, we need to have some uniformity, standardization with the education requirements, the education standards, which should be developed to meet the needs based on at the community level. So there could be variability from community to community, urban to rural versus what part of the country you're in and the system you're dealing with. So there's definite opportunity for variability.
Yeah. And I think that speaks to the power of this model of care going back to, is this, a dying field, an exploding field? This is where I think it's an exploding field because of that agility, that adaptability to make real change in the community in real time. as a member of the community, I certainly want my EMS clinicians educated and trained. But I agree with you that I think constraining it too soon without understanding what is the sandbox we're even playing in, and what training and education do I want someone to have to be able to function in that sandbox. That's the piece that I would want to know before further bringing in additional constraints to it.
Fantastic. So a lot of unknowns, a lot of kind of the Wild West as we're starting to get better understanding of, one, the difference between community paramedicine and mobile integrated health, but two, the legislative boundaries, the reimbursement, a lot to come, but it is an exciting and emerging aspect, subfield of EMS. So cool.
Can I add one
please.
Final thought? So you mentioned it's the Wild West, and in many ways I agree. And what I would hope that viewers and listeners take home is, I think that is an abundant positive. That is one of the coolest things of EMS, is the agility to respond to community needs in real time. EMS is capable of doing that at a pace that I don't think anyone else in the healthcare system is. With well-trained EMS clinicians and engaged medical director, you can respond to whatever community need it is that you have. And I think that is the secret sauce of community paramedicine and MIH that no one else in the health system has. So yes, Wild West, but that's an awesome thing to be right now.
Good. All right. Well, Dr. Alex Ulintz, thank you for joining me today to talk about differentiating community paramedicine and mobile integrated health, and kind of diving a little deeper on each as far as where we are and where they are in the profession or realm of EMS. So thank you very much.
Thanks for having me. I appreciate it.
And thank you for joining us. And as always, stay safe. Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications of upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to nremt.org. Thank you very much. And again, stay safe.